Good evening, friends. Today we'll be talking on SGLT inhibition, whether it is a diabetic molecule or a cardiac molecule or a nephrological molecule. Who has the right to claim right now whether the SGLT inhibition? So before going to SGLT inhibition, we'll see the continuum of cardio-renal-metabolic risk. See here you have got diabetes and hypertension, obviously obesity, dyslipidemia, everything goes together. Most of the time it causes endothelial dysfunction, and over a period of time that plaque formation atherosclerosis happens, and it can damage the kidneys, causing microalbuminuria, coronary artery causing myocardial infarction, and progressively can go into macroalbuminuria and frank renal failure, and MI and stroke can happen, leading to chronic kidney disease, heart failure, and end-stage kidney disease and cardiovascular death. So this is how the cardiovascular continuum happens. So to prevent that, we have to understand diabetes and then start working on it. So what does the data says about diabetes? So preventing diabetes is more important than trying to correct the MI or kidney failure or stroke. So prevention is far better. So almost 3 decades old, the UKPDS has clearly showed that 1% reduction HbA1c can decrease death by diabetes by 21%, MI by 14%, microvascular complication like retinopathy by 37%, and peripheral vascular disease by 43%, just mere 1% of HbA1c reduction. What does the current insulin diabetic therapy revolves around? So it revolves mostly on insulin-dependent mechanism of action. Either you take insulin, sulfonylurea, biguanides, DP4 inhibitor as well, alpha-glucosidase, glitazones or meglitinides. So everywhere, whatever you take, it's all about insulin-dependent mechanism of action. What are the limitations of it is, whenever you have hyperinsulinemia, insulin resistance, you are always bound to have weight gain. And when you do not take adequate food in between, it is hypoglycemia. And one, there is persistent need for insulin is there, beta cell fatigues, and you are going to have bloating and sensation and GI upsets. And always going to be insulin is an injectable thing, and if there is a reluctance, non-compliance from the patient. So this is the limitations of the insulin-dependent mechanism of action of diabetic therapy at this point. So we were in search of a new molecule, and everybody knows that from 2008 onwards, any diabetic molecule should also satisfy the cardiovascular outcome trial. So it means it should also have some cardiovascular outcome trial. So the new molecule in the recent time should have effective blood glucose lowering action, and low risk of hypoglycemia should be there, and weight neutral or weight loss should be there, complementary or synergistic mechanism of action, and it should last long, tolerated well, long-term safety should be there, and cardiovascular benefits should be there. So what does the current medication, whatever is available right now, metformin, ability to lower glucose is high, risk of hypoglycemia is low, but weight, maybe there is a small weight loss. There is a small amount, as I told you earlier, the UKPDS study, small amount of atherosclerotic cardiovascular disease benefit is there. And in heart failure, it might cause damage. And renal disease, it is neutral. Similarly, see here the latest DP4 inhibitor or sulfonylurea or insulin, almost have risk of hypoglycemia is always there with insulin sulfonylureas, and weight gain is always there. And effect on atherosclerotic cardiovascular disease is not there, and therefore heart failure cardiovascular disease, renal disease is not there. So not much of benefit is there except for metformin. Not much of benefit is there as far as cardiovascular renal disease is concerned. So we are in a hunt for a newer molecule which can satisfy most of the things whatever we are talking. So that is going to be SGLT inhibition. As a diabetic molecule, you know that glucose filtration happens in the kidney, and 90% of the glucose filtration is reabsorbed back in the proximal convoluted tubule by SGLT2 mediated mechanism. And SGLT1 has 10% control over reabsorption, so that no glucose excretion happens in normal individual. SGLT1 is mostly in intestine with some in kidney. So we are not bothered about SGLT1 action at all. So we are bothered about only SGLT2. So almost exclusively in kidney. So we'll talk about only SGLT inhibition. So now why you know why SGLT1 is not useful? SGLT2 is useful in diabetes practice. So what happens to the diabetes, the SGLT2 inhibition? See here, the SGLT2 inhibition is the red box which is there. So which prevents the reabsorption of glucose. So if it is not reabsorbed, means it is getting excreted. It goes to the distal part and gets excreted. So it plugs the SGLT2 inhibition, a receptor, and plugs it, and there is no absorption at all. It gets excreted. So see here, where does it? Normally, up to 180 milligram in non-diabetic version, the threshold is there. Up to 180 milligram, it won't allow the kidney to pass. Beyond which, in diabetic, it is up to 240 milligram, it won't allow the kidney to pass glucose. That is a normal. But in case of SGLT inhibition, even for 70 to 90 or 90 milligram itself, it allows the kidneys, prevents reabsorption, allows the kidney to excrete glucose. See here, how much from diabetics 240 and it is 70 to 80. It means that extra, whenever it exceeds 70 or 90, it is excreting the glucose. So that you are having anti-hyperglycemia. It is not hyperglycemia. It is anti-hyperglycemia. And since it is start working after 70, there is no hypoglycemia. See what a wonderful drug. It is fantastic anti-hyperglycemia after 70. It is no action below 70. So no hypoglycemia. So fantastic drug. So what happens over a period of time? Once the SGLT2 inhibition is there, it lowers plasma glucose because it is getting excreted in the kidney. So renal excretion. So when there is a glucose excreted, calorie loss happens and there is a weight loss. Once weight loss is there, your BP improves, your insulin sensitivity improves, everything improves. And metabolic switch to weight loss happens. So a simple excretion of glucose switches the metabolic engine towards a successful model. So that is the reason why SGLT2 inhibition as an anti-diabetic molecule is scoring over every other molecule at this point. So we'll see whether it is scoring over, whether it is effective or not. So here we can see whatever may be the baseline HbA1c to start with, either it is 8 or 9 or 10, you are seeing a decrease when compared to sitagliptin, which is being widely prescribed by most of our individuals. So it is better than sitagliptin because it is decreasing HbA1c to a larger extent than sitagliptin. Whether it is working alone or working with a combination. See, when you add metformin with the empagliflozin or sitagliptin, you can see here, empagliflozin works much better than sitagliptin. So in not only working alone, working with combination also, SGLT2 inhibition is very good. And you can see there is hardly any hypoglycemic episodes when compared to sulfonylureas. Hardly any hypoglycemia appear. So it is a wonderful drug. It is decreasing HbA1c. It is working in alone and working in combination with no hardly any hypoglycemia. And you are maintaining the weight loss because calorie is lost and weight is lost, and it is maintaining weight loss over a period of several years. So it means that it is going to work wonderfully well with all the metabolic adaptations to the newer side. And a bonus happens. Systolic BP is reduced because you are having natriuresis and glucosuria, osmodiuresis happens. There is decrease in BP as well. So this is where until now it was a diabetic molecule. Now I am seeing this as a cardiologic molecule. So I was talking about diabetic molecule wonderfully working, reducing HbA1c in as a single, as a combination. It works well. It reduces the weight loss. Suddenly you find systolic BP is reduced. So that is the reason why in 2014, when dapagliflozin was cleared for diabetes triplet treatment, it had some semblance of cardiovascular benefit. In 2021 to 19, they cleared for heart failure with the hospitalization for heart failure is reduced. So they cleared patients with diabetes. In 2020, without diabetes also, this is going to work, they understood. In 2021, in CKD also it is useful. So it's a complete molecule. So that is the reason why SGLT2 inhibition is started taking as a first line of therapy in high cardiac risk patients with diabetes. So now you understand why, where exactly the SGLT2 inhibition is standing now. It is standing right on top of the chart of our management of diabetes patient. See here, after lifestyle modification, it is the first line of therapy along with metformin. Especially when there is going to be a high cardiovascular risk, this molecule is a wonder molecule. So now we are moving from diabetes to hypertension. Suddenly you find this molecule reduces the blood pressure, both nocturnal pressure as well as during daytime, both systolic and diastolic BP. So it means that it is going to have an effect on the heart. And it is also having an effect on the fluid balance. Approximately, intravascular volume depletion occurs by 400 ml. This is a huge number because you have only 5 liters of blood, out of which 400 ml is excreted as in the urine. So it means that in heart failure, this is the extra excretion of fluid is going to have a superlative effect. So it is like a diuretic, loop diuretic. So, but without any side effect of loop diuretic. On top of it, it also improved kidney function. So suddenly you find a diabetic molecule trying to bring down the BP, excreting extra amount of fluid, and also improving the kidney function. Because it decreases the albuminuria, your kidney function is also improved. So I am changing the molecule from a diabetic molecule into a multi-system cardiac and nephrological molecule. So what does it do for the heart? See here, in heart, this is the heart myocyte. This is going to be a bit complex, but I'll make it simple. So the SGLT2 inhibition, this prevents this sodium hydrogen exchange. So once this hydrogen is not coming out and sodium, not allowing the sodium to come in, this sodium and the calcium exchange doesn't happen, and the calcium cannot come into the cell. So you are having less amount of ischemic toxicity to the cell. So directly it acts on the heart to improve the ischemia and also to have the increased production of ATP. So what does this other mechanism to influence the LV structure and function? See here, natriuresis, diuresis, glycosuria, intracolumn pressure is decreased so that the preload is decreased. Approximately, I told you 400 ml of your output is there. Fluid is excreted out, so it decreases the preload. So it improves the efficiency of the heart. It increases the oxygen supply, it decreases the oxidative stress, decrease the fibrosis, and neurohormone stimulation happens. This causes increased LV contractility, decreases the LV mass, and increases the diastolic dysfunction. And your endothelial function is improved, arterial wall stiffness is decreased, and vascularization decreased, so that the cardiac afterload, it means that cardiac preload is decreased, cardiac afterload is decreased, and your diastolic function is improved, systolic function is improved. So what more you want? SGLT2 inhibition is a complete package for the heart. Now I start claiming it is my molecule. It is not only a diabetic molecule. You can prescribe if you want, but it is predominantly a cardiac molecule. So it gives complete package to the heart. So it is now becoming a cardiac molecule. So what does it special about SGLT inhibition? See here, your loop diuretic decreases your intravascular volume. Intravascular volume decreases always can have an alteration in the GFR. Whereas SGLT inhibition has an action more on the interstitial volume as well. So it means that the arterial wall thickness is decreased, stiffness is decreased, so that the afterload is decreased. So which drug has a preload and afterload reducing effect? AC inhibitor or ARNI, ARB. So similar action is there with SGLT inhibition. So you are having a molecule which is decreasing the weight, decreasing the BP, why acts like a AC inhibitor or an ARNI. See the effect on the blood volume with SGLT inhibition and loop diuretic. See, loop diuretic has a modest decrease in blood volume, whereas loop diuretic will have more decrease. So that means that it is going to have a harmful effect on the kidney function. Whereas interstitial fluid volume is decreased to a larger extent, so that your arterial wall thickness is reduced, stiffness is reduced, so that the patient has got a decrease afterload. So that is the reason why SGLT2 inhibition stands tall and like your first choice of medication in diabetes, cardiac molecule, heart failure, SGLT2 inhibition stands as the first line of therapy. Now, how we have taken the SGLT2 molecule from diabetologist into cardiologist. So cardiologist first line of medication has to be SGLT2 inhibition in heart failure. So this is the first line of medication, first choice. So now you know that SGLT2 inhibition has a decrease in cardiovascular mortality. See, over and above, this simvastatin, over a statin, AC inhibitor, spironolactone, ARNI, everything is decreasing and cardiovascular benefit is there. And over and above, SGLT inhibition works wonderfully to decrease your cardiovascular death. So it means now, after all the molecules now, you have got a wonder molecule which can decrease the cardiovascular death. Hospitalization for heart failure, this is one of the prime molecule. All-cause mortality, this is one of the prime molecule. So that you know that it is nothing to do with the other molecule, irrespective of blood pressure, irrespective of LDL cholesterol, irrespective of HbA1c, your cardiovascular mortality is decreased. So it means that it is predominantly a cardiovascular molecule now. Irrespective of HbA1c, cardiovascular mortality is reduced. So it is a cardiovascular molecule. Now I am shifting gears and saying it is a cardiovascular molecule. And also it decreases HbA1c to a minor extent. So it is mainly a cardiovascular molecule. So mainly a cardiovascular molecule, mainly a heart failure molecule. Now you know that heart failure activates sympathetic and renin-angiotensin-aldosterone system, which can increase lipolysis, lipogenesis, gluconeogenesis, and can increase the insulin resistance and can worsen diabetes. So a heart failure can worsen diabetes over a period of time. And similarly, diabetes hyperglycemia can result in increased myocardial necrosis, calcium channel alteration, and LV remodeling happens, and it can worsen the heart failure. So diabetes and heart failure go hand in hand. So you are having a molecule which decreases the HbA1c and also cures the heart failure. Now we are decreasing, we are always talking about heart failure means heart failure with reduced ejection fraction. Now you know that heart failure with reduced ejection fraction and heart failure with preserved ejection fraction both have almost similar amount of mortality. And pathophysiology-wise, impaired diastolic function means abnormal filling and twisting of the heart during diastolic, leading to elevated left ventricular end diastolic pressure and passive myocardial stiffening. So it means that extracellular fibrosis and infiltrative process is occurring in the long term or causing diastolic dysfunction, which results in heart failure with preserved ejection fraction. See here, the proposed mechanism of preserved ejection fraction is your risk factor like diabetes, hypertension, obesity, chronic kidney disease can influence the heart. It can cause decreased nitric oxide bioavailability. Myocardial filament stiffness happens. The protein kinase signaling molecule is altered. Fibro increase resulting in increased fibrosis, stiffening of the heart. LVH happens. Sodium overload happens. Thereby calcium overload happens. And you're resulting in increased myocardial wall stress and more ischemia and more death. To prevent that, see here, the cardiac remodeling and vasoconstriction, the center of it is SGLT2 inhibition. Rest of the molecule is acting on the periphery. The cornerstone now in heart failure with preserved ejection fraction is SGLT2 inhibition. See here, whatever the preserved ejection fraction, whatever the pathophysiology happened, it is exactly opposite, doing opposite. It is decreasing the fibrosis, decreasing hypertrophy, decreasing sodium overload, decreasing the signal molecule, so that you are having reversal of diastolic stiffness and preserved ejection fraction treatment. So until now, we were not having any recognized molecule for preserved ejection fraction. Now you know that you are having a molecule which has been, as per the guideline, which we can give it for heart failure with preserved ejection for diastolic heart failure. So this is the based on this trial only, you can see the LV mass index is decreased, so that the wall stiffness is decreased, and patient has got a improved diastolic relaxation. So moving from heart, now you know both systolic and diastolic heart failure. This is going to be the molecule of choice. It lies the first line of therapy for both systolic and diastolic heart failure. So you cannot, any cardiac patient with failure cannot have a prescription without SGLT2 inhibition. So now what happens to the kidneys? See here, because the proximal renal tubular glycosuria and native sodium excretion natriuresis is happening, there is decrease in the intraglomerular pressure. This can cause decrease in albuminuria. See here, very, very, very important. To preserve the renal function, decreasing albuminuria is there. Until now, we thought AC inhibitor, ARB or ARNI is the one which does all these things. Now we have got a molecule which can decrease albuminuria. So it is taking place, taking every system into its fold and giving a cure for it. So it preserves systemic sodium and water hemostasis, decrease in the blood pressure, increase in the arterial stiffness is favorably altered, so that afterload is reduced, preload is reduced, cardiac workload is reduced, as well as kidney is also functioning improved. So SGLT inhibition, we thought it was only a diabetic molecule because it was improving the insulin sensitivity, improving the glucagon, and decreasing the glucotoxicity and decreasing the body weight. But you know that heart failure is decreased, cardiac death is decreased, blood pressure is decreased, and increase in the oxygen delivery happens, and utilization of ATP is high, and decreased arterial stiffness. The same thing benefit goes with the similar action. Intraglomerular pressure is decreased, albuminuria is decreased, natriuresis glycosuria happens, and the patient has got a favorable outcome. So SGLT inhibition, to put in a nutshell, it has moved out of only diabetic management. If you want, you can prescribe, but it has to be prescribed in heart failure. It has to be prescribed in diabetic kidney disease. So this prevents a heart attack, prevents a cardiac event, prevents a heart failure, treats a heart failure, prevents a kidney disease, and it is a complete package for the whole body in the management of diabetes and diabetes-related complication, as well as non-diabetic individual. See here, reduction in body weight, reducing blood pressure, natriuresis, anti-inflammation, antifibrotic, reduction in extracellular matrix turnover. So everything is in favor of as a cardio-renal molecule. See here, cardio-renal molecule, SGLT inhibition, natriuresis glucosuria, tubulo-glomerular feedback, so that intraglomerular pressure reduction happens and blood pressure lowering happens, and this can protect the kidney and also protect the cardiovascular. So complete cardiovascular renal protection happens with SGL2 inhibition. It's a complete package for cardiac molecule. So now we understand and now we know it is a complete molecule for cardiovascular and renal disease. So without this prescription, it should not be there. Every patient should have, except for the contraindication where your patient on dialysis or the patient has a very low EGFR, you can prescribe every patient with SGLT2 inhibition. So what is the problem? It is excreting glucose. So it means that patient can have genital mycotic infection. Balanitis and balanoposthitis can happen. Candida can happen. Recurrent UTI, urosepsis, and pyelonephritis can happen. So what to do? Good personal hygiene, genital area hygiene is the order. Washing genital area from after each visit to toilet. Retract the prepuce and wash. Circumscribe the male individual. Avoid unusual sexual exposure and immediate medical attention symptoms. So these are something which to prevent a very good molecules preservation and continuation of the molecule. And volume depletion in a normal region can cause postural hypotension. So that patients should be advised, except in heart failure patient, to they drink adequate amount of water. Hypoglycemia is very, very rare unless you giving medication along with other insulins or sulfonylurea. Otherwise, hypoglycemia is very, very rare. And one another concern is euglycemic DKA. Once you take this medication, the simple to avoid is take food. It will take care of your HbA1c. Do not fast. If you are fasting, this molecule will cause DKA, euglycemic DKA. So take food that is sufficient. Other rare effects like lower limb amputation with canogliflozin, that is not a total group effect. It is a single molecule effect. Bone fracture with canogliflozin, which we no longer use as a common molecule. Rarely you have LDL cholesterol increase. Fourniers gangrene also is a problem. So SGL2 inhibition over and above, most of the times it is favorable. There are small unfavorable effects are there. So prevention and the prevention of incident and treatment of established heart failure, reduction of major cardiovascular events, reduction of blood pressure and weight, preservation of renal function, and also improvement in glycemia. So much of favorable effects are there with SGLT inhibition, which cannot be ignored. And this molecule should be in prescription with most of the patients with diabetes, cardiac patients, and renal patients. So how do you individualize the care for patients? Anything a patient has established cardiovascular decrease. If you want to decrease cardiovascular mortality, add SGLT inhibition, as simple as that. Potential cardiovascular benefit, the other molecules are metformin. In heart failure, both systolic and diastolic, all glyphosate, SGLT inhibitions are there or need to be used. So to avoid pioglitazone, rosiglitazone, saxagliptin should be avoided. Metformin in decompensated heart failure to prevent lactic acidosis and worsening of heart failure. In chronic kidney disease, to prevent progression of nephropathy, SGLT inhibition is one of the topmost molecule to be. It decreases the intraglomerular pressure and it prevents the progression of nephropathy. Can be used at any GFR. This SGLT cannot be used at any GFR less than 30 ml. You have to be very, very cautious about it. And patient on dialysis, you should not use it. Whereas any diabetic molecule, like glipizide, glimepiride, pioglitazone can be used in any GFR. So reduced dose or avoid using in reduced GFR. So whenever there is GFR is reduced, try and reduce the dose or exclude this molecule from the prescription. Whenever there is use medication, less risk of hypoglycemia, especially in older adult, you can use older adult because of the enlarged prostate. SGLT inhibition is not the drug of choice. DIM4 inhibitor and GLP-1 analogs, thiazolidine can be used. And obviously, hypoglycemic drugs cannot be used frequently. In obesity, weight loss program, SGLT inhibition stands tall for weight loss. And GLP-1 analog can be used as a weight loss medication. Rest of the molecules are weight neutral, and insulin-dependent molecules are weight-gaining molecules. Gastrointestinal disease, NASH, non-alcoholic steatohepatitis, pioglitazone and relaglutide are much more common, and SGLT2 inhibition will take over in future. And in GI symptom-wise, metformin is big trouble, where it can cause dyspepsia and vitamin B12 deficiency as well. Advanced liver disease, we cannot use metformin. Likelihood of having pancreatitis is always there with GLP-1 analog and DP4. Gallbladder disease is there with liraglutide. So I'm just giving a cardiologist giving advice on diabetes, so you can have your own decision. So candidates for initiation of SGLT inhibition, likewise, it is from the cardiologist point of view. Patient with a high cardiovascular risk with type 2 diabetes always start with SGLT inhibition as one of the molecule. So any molecule, canagliflozin, DAPA, or empagliflozin with similar efficacy as far as diabetes is concerned. So start dose once daily in afternoon, and you can combine with metformin. Combination therapy works wonderfully well. Whenever there is a stable hemodynamics and clinical efficiency, pre-initiation eGFR should be done. If it is less than 45, do not start. Otherwise, start the SGLT inhibition. So every prescription should contain both diabetes, cardiac, and renal should contain, if there is no contraindication, SGLT inhibition. What we have to counsel for genital and perineal hygiene, orthostatic hypotension, adequate hydration, food examination, symptoms of euglycemic DKA, adequate amount of calorie daily, no fasting, avoid excessive alcohol, and multidisciplinary care should be there. And follow serial assessment of renal function and eGFR should be there. And preservation of the heart failure function should be monitored. And diabetes, obviously, the combination therapy to monitor the diabetic state as well. So overall, SGLT2 inhibition is going to be the magic molecule for 2020 to 30 until the next molecule comes. This is going to be the molecule of choice and the most prescribed molecule of this decade. Thanks for your listening. I'll stop sharing. I'll unmute you, and you can always unmute yourself and ask question whoever wants.
Good evening, sir.
Sir, good evening, sir.
Please, sir. Good evening, sir.
Sir, when we are using SGLT inhibitor, so there is a chance for increased frequency of urination, sir.
Yes, sir.
Sir,